So now we are going to listen to Dora Pereira, who is a clinical psychologist, invited professor of the University of Madeira. She is a professor on psychopathology, and afterwards we will listen to Ashok Bhattacharya, is it? Who is a psychiatrist working with adults, individual and couple, from 8 to 80, isn't it? 18 to 80. He's from Canada, central Canada, from a little city like Évora, near Toronto. So let's begin with Dora. Thank you.
Hello everyone. Thank you for being here and for listening to this presentation. As Dr. Izara said, I've been working as a clinical psychologist for 17 years in child maltreatment field, and now I'm having a new experience as in an academic position at the University of Madeira, in an island in the middle of the Atlantic, very, very beautiful. And now I want to talk to you about this relation and some thoughts I had about parenting and or mental health. These thoughts I will talk to you about are some results of my research project, my doctoral project about parenting capacity assessment. Some questions that arise many times about parenting and or mental health issues are something like this. How mental health impacts parenting? At what point is parenting impaired and is detrimental to the child's development? And problems in childhood are predictors of problems as adults. Are children in risk? Are there protective factors? So many questions that professionals in this work field face every day and must give answers to the courts, must give answers to the parents and to other professionals. So I want to start thinking about this in a little different way. Many times we see in research projects how mental health impairs parenting and impact parenting, but most of the times we used to talk about how parenting is affected in parenting skills. Well, I think it's not just parenting skills. It's the impact on parenting is on parenting capacity, mediating processes, and parenting skills. It's much more complex. And I'm basing myself in such a model like this. Thinking about parenting capacity, not just something that arises from the psychic structure of the parents, but also from contextual modifiers and relational modifiers. What I want to say is that parenting capacity is not just made about the psychic structure of the parent, but also about how the context helps to improve or not the parenting capacity and how the relations this parent or this father or this mother has with this social network helps also to improve or not parenting capacity. And with this parenting capacity, this structure, I used to say the common ground, there is where something more will arise. Skills, parenting skills, usually the picture that we take of parenting. Most of the times we say parentings are good enough or not parents if they care in adequate ways about their children. And we talk about affection, we talked about attachment, we talked about how to take care of health issues, educational issues, and we are talking about parenting skills, yes. But we have more. We have parental capacity and we have mediating process. What are these mediating processes? Are also the processes that allow the parent to take in action these capacities in parenting skills. And I'm talking about impulse control, the assumption of the responsibility, and the capacity this parent has to be in intervention, in some kind of intervention. So, and also to finish this model, we must think about parenting in a synchronic perspective, but also on a diachronic perspective. This changes over the time. It's not just a picture, it's a movie. Okay? And so some remarks about this issue. Based on this model, I think we can talk about a hierarchical impact. If we have an impaired parent capacity, so it's more probable that we'll find parenting skills also impaired. But different psychopathological disorders impact different parenting behavior elements. We cannot say that all the disorders have the same impact on the same elements. We have different impacts in different elements. So, on parenting skills, we can say most of the studies are focused on this, and some remarks, some authors say that mothers with psychotic spectrum disorders are less sensitive, more distant, more intrusive and self-centered to their babies than mothers with mood disorders. And babies tend to avoid mother's gaze, what authors read as a self-regulation strategy and a sign of major vulnerability to stress. And, for example, one of the most common results of research say to us that parents with severe mental health problems most of the times are not available in a consistent way to be aware and respond to the child's needs. Physical and emotional neglect being observed at that times. But we can also find that some psychopathological disorders impact impulse control. For example, borderline personality disorders, impulse control disorders, what may increase the child abuse risk, and also difficulties in interpersonal relation with potential helpers. It's more difficult when parents have difficulties in this area. Others impact the capacity to reflect about his or her own behavior and how it influences child development. So it's more difficult to be in an intervention to reflect about his own behavior. These features lessen the probability to benefit from an intervention and to make it possible. It's not just a wanting question, it's possible to work with and to get results in the time useful for child development. And about parenting capacity, well, we know that psychopathological disorders impairs parental functioning in many ways. Some of these aspects are much talked in research. We're here to talk about the theory of mind, the impact on attachment processes, how parents are less able to have in mind and fulfill the child's needs. And also, for example, some French authors talk about toxic parents, the way parents are detrimental to child's development. And we have some psychopathological disorders more studied as depression, psychotic spectrum disorders, or borderline, and it's lacking there substance abuse disorders, and less studied post-traumatic stress disorder, for example, or obsessive-compulsive. We have many work to do in this area about impact on parenting capacity, let's say. So, about contextual modifiers, parents refer that frequently they found difficulties in these areas that can impair parental capacity. Financial problems to cope with disorder symptoms, especially during acute phases, to cope with side effects of medication, to get access to childcare services, for example, respite care, And this is much important when we think that these parents frequently must go to health services. To cope with fear and stress related to the possibility of being separated from his children, very frequently said that, and to cope with stigma directed to children and themselves, not just themselves, but also the children. And when you talk about relational modifiers, it's important to point to two main protective factors. Positive relation between parents and family members, neighbors, professionals, could reinforce these resilience processes and assure continuity. This is very important to access how the parent relates. It's not just is able or is not able, but how it relates with the social network. And if the family members are aware of the main difficulties and performing a containing and supportive role with parents and children. If we think and hold this, how does this problem impact children? Most talked about in attachment processes that are related to this lack of continuity in care and difficulties in mentalizing. Another way, it's about hypervigilance, insecurity and stress. These children have more difficulties on emotional self-regulation. They have frequently feelings of not being understood and more anxiety. And frequently we see these children as parents of their parents. They are the children that are taking care, and they are trying to minimize his or her own needs, fearing to be separated from his mother or father. Okay? So, how can we access these parents in child protection field? And I think to professionals that work on mental health services, how can they contribute to this kind of assessments? I think that these kind of assessments should integrate all the elements of parenting behavior and not just one of them as parenting skills. Psychiatric assessment is not parenting assessment. Psychological assessment is not parenting assessment. It's much more. Parenting assessment, it's more than that. So, parenting assessment conclusions aren't a matter of yes or no. Is able or is a good parent or is not a good parent. It's much more complex. And parenting capacity, I think, is a comprehensive process about parental functioning which aim to justify future interventions with the parents and children and protective measures also. So parents are not a disorder, and we should look for resources, not just for problems. Especially important with parents that have mental illness, to see if they recognize the impact of their behavior in children, how is his or her social network functioning, and how parents deal with mental disorder, namely with risk for children. So I think that the Parenting Capacities Assessment Guide, I will talk about you briefly, could be a useful tool for assessment in child protection. It's a tool based on clinical judgments, not a checklist, and it aims to get as closer as possible of a comprehensive and dynamic understanding of parenting functioning. It's like this. It has 9 dimensions of evaluation: family, health, child health and development, attachment, parenting skills, and impulse control, responsibility recognition, personal factors, social support network, and access to services. It's a comprehensive evaluation. I don't have time to talk about these main questions. If you want more information, I can give you. In this board shows the main questions that are raised in each of the dimensions assessed. These are based on a multi-method and multi-source of information work. It's not a work to be done in one session. It's a work to be done in a month and a half at least. Okay? It's a comprehensive process. It's not just to look and to say something. It's much more. And in the end of this process, we get a parenting capacity profile. And each dimension is classified as a main resource, a secondary resource, a main difficult, or a secondary difficult. For each one, we have specific criteria, and we can obtain a change prognosis with an encouraging change potential or a high risk of becoming a chronic situation. This dimension are the one that are mostly related with mental health, because in this dimension we assess personal factors that impair parenting capacity, looking for personal positive characteristics, but also for some problems that can be signs of psychopathology. It's not a psychiatric evaluation. It points the need to do a more profound assessment in the psychiatric services, but points are there these kind of problems or not. In the end of each dimension, we have synthesis questions as like these that help us to make a clinical judgment about each of the dimensions assessed and to report the results. The study that has been done has focused on ecological validity, reliability studies, and predictive validity. About reliability, we made a qualitative study, about 10 cases. 13 parents were assessed, and what was made, this evaluation was made by 2 teams that usually in our protective system are involved in the work of the parents, namely the temporary shelter team where the children were in care, a multidisciplinary team to CURT support, or a local board team in child protection, and me as an investigator. We meet together, we shared information, we had used the guide independently, and after we had another meeting, we discussed how we agree or disagree, and we look for the tool again. And we get promising values of agreement, inter-rater agreement. And I think this is just an exploratory study that has been developed here in Alentejo, but this is a promising result to invite us to continue this kind of studies and to look for the guide as a potential reliable tool in child protection field. To conclude, I think that about assessment process, parenting assessment, it's a how question, not a yes or no question. And this guide could be a useful tool to help professionals make a clinical judgment, but validation studies must continue also. And about intervention, I think that this impact of mental health in parenting points us to the need that we must look not just for an adult to the mental disorder, but also to the children, but also to the family. So we need to work in network between the child protective services and the adult mental health service, not just being reactive to a dangerous situation or a risky situation, but to act preventively and as resilience builders. And I think this tool would help. I finish with this statement that is in the study of Bernstein, that says some people see that I am mental illness heavy. Not heavy, you know. I said, my name is not heavy bipolar. My name is heavy, and I have bipolar disorder. Thank you for your attention.
Thank you very much for asking me to speak at this conference. It's a pleasure. So I'm a psychiatrist and I work in Ontario, Canada. I have no conflicts of interest, which means that no drug companies have paid for this speech today. So I've been in practice for 30 years. I see mostly professionals and students. I do quite a lot of couple therapy because I live in a small town, so the divorce rate is high. And my clients are anywhere from 80 to 18 years of age, and I work 45 hours a week. So I'm going to look at burnout, differentiate it from depression, identify the factors that lead to burnout, maybe give you a chance for some self-assessment on how to make change. So it took the American Psychiatric Association 35 years to have post-traumatic stress as a psychiatric condition in the DSM-3, 1980. The first person to describe burnout was Freudenberger in 1974. He himself got burnt out a number of times treating drug addicts in San Francisco. So the question about burnout, is it work-related? Is it really a disease, or is it not a disease? So the ICD-9 says yes, American Psychiatric says no. Maslach in 1981 published her study on burnout that described 3 essential features of burnout: exhaustion, which is physical or emotional exhaustion; depersonalization, not feeling quite like yourself anymore, feeling numb; and a reduced efficiency, which is either real or perceived, and this is important. They also started a journal in just 2014 with Michael Leiter. So who gets burned out? Well, residents and medical students get burnt out, practicing physicians get burnt out, and the reports show that between 20 and 75% of people get burnt out, which means most of you. This quick slide, this is on 15,000 doctors in the United States. It's done every year, looking at burnout in doctors. The most stressed out people are female urologists. The Happy Doc study in 2005 showed that there's a lot of intimidation and harassment while medical students are training that can cause mental health issues with themselves. So it's important for us as teachers to be a good role model to each other, but also to the students that are still in the nest that we share. Female physicians have more trouble conceiving, keeping their pregnancies, perhaps because they're having pregnancies later. They also have more miscarriages. So let's just run through a typical case study. This is Aaron Norris. So he gets into medical school. He's proud, he's praised, and he's respected. And he gets married. Then he wants success. He wants success through his career. He wants success through his family, financial success, and he wants to reach the top of that mountain. And he wants to push and push and push. The more he pushes, interesting, this study looking at narcissism in doctors, a rare trait I might add, but the more narcissistic doctors are, the more likely they're going to have denial before they get help. Then they run into time management problems. When do I work? When do I play? When do I have time for my kids or my partner? The final stage is cynicism. I just don't care. The other phrase for this might be compassionate fatigue. This is when they end up seeing me. So sometimes doctors make a professional mistake. So the error rate in being a doctor is higher in burnt out doctors. Sometimes there's a divorce. Sometimes there's a physical problem. Oftentimes this is confused with depression. A little picture of my office. So I do a lot of couple therapy, as I mentioned, and a little bit of psychoanalysis. So this is the Berlin Wall. I got a chance to pick away at it a number of years ago. It's important that we have to reduce the walls between each other, talking about burnout. How many people were asked how they wanted their life to look when they were in medical school or in a PhD program? Not too many. How do you want your life to look? Stressed out? Maybe a little bit more relaxed. So what do we know about stress? Well, Harlow and Harlow used to torture monkeys in the early 60s. Hans Selye actually used to chase around his rats in his laboratory with a hockey stick. A lot of them got stressed out. And Robert Sapolsky studies baboons in Africa, now for about 35 years. Apparently baboons spend about 4 hours a day working. The rest of the day, besides sleeping, they spend bullying each other. So it's a good model of human behavior there. Holmes and Rahi were two psychiatrists who looked at 5,000 charts of people before they got into hospital and determined in the 3 months prior to hospitalization what caused that hospitalization, what was going on in their life, and came up with a scale. If you got 300 points on this scale, you had a 90% chance of having a heart attack. Item 25 is a bit small right now, is outstanding professional achievement, also causes stress. So burnout versus depression. Depression is usually triggered by a loss. Burnout is usually triggered by a gain. And the energy level in burnout might initially increase, and also there's a false hope that begins to develop as opposed to the loss of hope that one sees in depression. So who are these people that are getting burnt out? Well, doctors tend to be pretty outgoing, responsible, controlling, people-pleasing type of people. We tend to also are self-doubting. Micelles in 1972 put marshmallows in front of 4-year-old children and gave the simple request, wait until I come back in 5 minutes to eat these marshmallows. In 20 years later, he checked their SAT scores, which is the admission to universities, and there was a 20% increase in those kids who were able to wait to eat the marshmallows. Probably became doctors. So empathy is experiencing someone else's experience from their point of view while negating your point of view. This is where this all is happening. The same place that post-traumatic stress happens, in the limbic system. And if you're asked to imagine someone else, if you're watching someone in trauma and asked to imagine yourself being in it, there's another place that lights up, the green part. So the more you actually engage the other person's experience, the more likely you're going to get stressed by it. Either an issue of control or support or power. When those get imbalanced, that's usually when people get burned out. So this was an owl in my backyard that I thought really well represented the look of work engagement. Work engagement is the opposite of burning out. Ask yourself any of these questions. Do you feel like you're bursting with energy at work? Do you feel strong and vigorous? Do you feel like going to work when you get up in the morning? I could work all day long. I'm resilient mentally when I go to work. Even when things aren't going well, I like to persevere. Dedication. I find the work that I do is full of meaning and purpose. I am enthusiastic about my job. My job inspires me. I am proud of the work that I do. To me, my job is challenging. How about absorption? Time flies when I'm working. When I'm working, I forget everything else around me. I feel happy when I'm working intensely. I'm immersed in my work. I get carried away when I'm working. It is difficult to detach myself from my job. Michael Leiter has set up a civility program where they'll go into hospitals and simply get the staff to treat each other with civility. Those hospitals have a 20% increase in the patient satisfaction rates on surveys when they're released from the hospital. So who do we find stressful? Well, it's kind of each other, like those baboons. Colleagues, sometimes, supervisors, patients. Do you guys have ratemd.com? So this is a website that your patients can go on and rate you as a doctor that's available to the public in Canada. Sometimes that's stressful. Getting professional complaints can be very stressful. So how do you reverse burnout? Well, let's look about cooling in. Maybe you need to learn to balance your life. I belong to a support group. We meet once a month. There's a group of us. We talk about our career and our jobs, but also about other things that are worrying us professionally. Maybe you're drinking too much to manage your burnout issues. Maybe you need to reevaluate your personal attitudes. A lot of doctors find trouble saying no. They might mean no, but they might say no, and that's a often common problem. You need to develop interests outside of the workplace. Maybe do volunteer work. Maybe reevaluate your need for perfectionism. Learn to delegate and ask for assistance when you're in trouble. Take time off, come to Portugal. It's important to exercise. we always underestimate the value of exercise in depression. Exercise is in many studies as valuable as Prozac in managing a depressive episode. Maybe you need to take yourself a little less seriously. So this is a hummingbird that comes to my backyard at 5 o'clock every day. And this is the same hummingbird. I caught him on a twig. And I caught him on a twig, and I was fascinated because they go into a stage called torpor, where sometimes they are so exhausted they'll fall upside down. And they're not dead, they're just taking a rest. During sex, their heart rate is 1,250 beats per minute. When they're in torpor, it's down to 50. They're pausing. So when life chops you down, it's okay to have some hope. Maybe call a colleague or call your professional organization or get therapy. And just do something different. Thank you.
Thank you.